6.5 millimeters of axial length or minus 6 to 8 diopters of myopia. And you know that this high myopia is a potential source for, retinal complications. You have two parts. On one hand, we have peripheral rays, as Dr. Heyman is going to speak about. In these cases, they have, high myopes have, vitreous abnormalities, and they have, very irregular, posterior border of the vitreous base that make these breaks so posterior and so irregular. And on the other hand, we have the posterior part of the eye, and this is the problem. And some of these patients, they develop, deformity of the posterior eye wall that we call posterior staphyloma, that Rick Spade defined as, outputting of the eye wall that has a radius of curvature that is shorter than the surrounding curvature of the eye wall. Now, how many of these eyes with more than 26.5 millimeters of axial length have posterior staphyloma? We studied, a Spanish population comparing to Japanese population in Matsui, and we described how to, over all of these eyes, half of them will show posterior staphyloma. And the axial length is not a reliable, parameter to indicate the presence of the absence of posterior staphyloma. This is a picture of this draw from, James Corting described 10 types of posterior staphyloma. Some of them, they affect the macular area, but some they don't. For example, type 4 is a nasal staphyloma. These patients are not to cause, but are not to show this macular traction maculopathy. Type 5 is pretty similar when you have these staphylomas that the border is near the foveal area. These are pictures with eyes with posterior staphyloma. You see type 1, you have white, staphyloma. Type 2, only macular staphyloma. Type 4, as I told you, type 4 is not to have myopic macular traction maculopathy because, the staphyloma is the nasal area and the macula seems pretty normal. Duplicated septal, and type 5, as is going in many cases, they're going to show another kind of problems, as you can see here, RP lesions. This was described with the OCT. It was mentioned before in 58 by Phillips. So, it was described using the OCT in 1999 by Takano and Kishi. But this is not until 2004 that the name appeared, macular traction maculopathy, to describe the macular changes that happen in cases with posterior staphyloma and vitreoretinal traction. All of these pictures, in some papers have been related to macular traction maculopathy. A previous speaker has spoken about lamellar macular hole. I think, it happens also in the tropic eyes. This is a more focal problem than macular traction maculopathy. And remember that in high myopes, it may evolve to full thickness macular hole. Schisis, you can see outer schisis, middle schisis, and inner schisis. You can see how in some of these cases develop, like a central macular hole. But if you take a look, a closer look, you will see how the outer retina remains there. In the middle is not a macular hole, it's a schisis only. And you can see in the right how the focal detachment. You have two main kinds of full thickness macular holes. Macular hole without the schisis. I don't consider this part of macular traction maculopathy. Kobayashi described in 2002 that the area, volume, and depth of these macular holes are pretty similar to tropic eyes. And macular hole with the schisis is part of this syndrome. And at the end, all of these can end with full thickness macular hole retinal detachment. How many of these eyes with high myopia will develop schisis is described in the literature between 9 and 34%. And I'm going to try to answer your 4 questions. First, is this a stable condition? Second, when do we have to consider surgery? Are there any factors to establish the prognosis with the surgical technique? Is this a stable condition? The answer is no. This is not, don't consider this a stable condition. There are 2 papers that I advise you to read. One is from the group of Gaucher, the group of Alain Godric. They published 39 eyes with a mean follow-up of 31 months. 69%, near 70% of eyes showed evolution, showed worsening during follow-up. And down you can see another group, they showed that when the schisis affects the central macula, nearly 50% of eyes evolve. But this is only 36.2 months of median follow-up. Then let me show you one case. This is very important for me. Look at this. This is the first case I did in 2004. I performed macrobacca. I started in 2004. And you can see in the upper row. And I did the surgery. At that time, it didn't exist. It was very flat. I did the surgery. The macro hole remained open. And you can see how we closed the hole with the macrobacca. But look at the other eye. You know, the right eye. In 2004 was normal, was a deep staphyloma. 2010 was a slight, outer schisis, mainly in the nasal side. In 2011, it increased. In 2012, it increased more, and I lost the follow-up of the patient. 3 months ago, the patient went with the bottom and right and left. You will see how there is an inner macro hole in elevation in the schisis. And the patient, told me, okay, I will be operated on September 22. But the patient came on August 22 with a full fixed macro hole retinal detachment. Is the bottom right is the first picture after the surgery. Then it's not a stable condition. Second is, when do we have to consider surgery? Remember, visual acuity may be good in the initial schisis. You can see two cases, 3 and 4 years after the initial control, as you can see, increase the schisis. It can be difficult to consider visual acuity because visual acuity does not reflect exactly what vision is. Consider the OCT. OCT from the schisis to foveal detachment. When the foveal detachment appears, is the main indication, in my opinion, to consider surgery. Look at this case, 2010. In 2013, the patient told me, okay, I noticed something when I'm breathing. And tiny foveal detachment. Then 2014, 2015, at the end, this patient was operated because, she had another systemic problem. She couldn't be operated before. Metamorphopsia may be present, but this is not a sign of progression of the schisis. Always when the patient have metamorphopsia, consider to rule out a choroidal neovascularization. Any factors to establish the prognosis, visual acuity, of course. In the parenchymal membrane, we saw the same. In all the cases, if full finished macro hole, if you have better vision, you will have better vision post-op. Then it's the same here. You have better vision pre-op, you will have better vision post-op. But, 3 things about the OCT. First, don't rely on one cut. Review all the cuts. Look at this. In the first row, you see the schisis with foveal detachment. Is that true? No, it's not true. This patient had a foveal, a schisis with a macro hole. Second thing, take a look at the breaches of the schisis. Look at this. In the left, you have all the breaches of the, Henle fibers and Miller cells, and all these breaches. And in the right, these. All the breaches, many of them disappear. In these cases, even you operate on, you decrease the schisis, you make them disappear, and the patient lost vision in some cases. And take a look in the interdigitation area, what we call interdigitation area. This is not more than the terminal ends of photoreceptors. Look at this continuous line in the left, this continuous line in the right. This is a very poor prognosis. Technique. Technique is very simple. Use the parasplanum, retractable impairing the spinal phobia in the areas of staphyloma. The most important thing here is to distinguish between the posterior hillock and the internal limiting membrane and leave like this. Don't try to be very centered near the foveal detachment. And we have to tamponade. Tamponade is a very bad concept because there is no holes in schisis. But many papers in the literature, they speak about tamponade. Look at this. But let me show you this case. In some cases, you can have this, tiny remove from the foveal detachment. You do the surgery, excuse me, because of the video, the camera was not good, and then we build the ILM just to the borders of the perifoveal area. We remain like this, we trim the internal limiting membrane, and this is what happened after the surgery. Look at this, macro hole. Why? I asked him why this? If you take a look in the literature, you will find papers saying that if you leave gas, you will have a better result in rapid resolution of the foveal detachment, while other Studies say that vitrectomy with gas has more complications and does not significantly influence the proportion of visual acuity. What happened in my case? I think in my case this happened. You have a tiny roof. In the beginning, the air compress the foveal area, but when I arrive in the middle, you compress the foveal area, and then the weakest point is the central fovea, and then this made the cause of the macro hole. If you take a look in the literature, you will find a paper from Japanese group that showed that the intermediate tampoline may push the subretinal fluid inside the limited area of the focal detachment of the staphyloma to the weakest point, that is the fovea. Then, in conclusion, in summary, macular traction maculopathy is not a stable disease. Don't consider it a stable disease. Consider to perform OCT periodically. Consider surgery based on vision or initial formation of the focal detachment. And if you perform the surgery